Hello, everyone. My name is Solome Tibabu. I'm the host of the Going Digital Behavioral Health Tech Conference, and I'm thrilled to have Stephen Smith here today with us, founder and CEO of NOCD. Welcome, Stephen. Can you give us a little introduction?
Hi, Solme. Thank you very much for having us. My name is Stephen Smith. I'm the co-founder and CEO of NOCD, and NOCD provides online therapy for obsessive compulsive disorder, one of the most severe, prevalent, and misunderstood behavioral health populations. It's considered a serious mental illness, and it's also, a very effective. It's a very treatable SMI, right? ERP, exposure response prevention therapy, is the gold standard, and we're the largest provider in the world of that treatment. So my story. So I have OCD. I was misdiagnosed 5 times with the condition. I was diagnosed for having anxiety and depression, symptoms of untreated OCD. And because I was misdiagnosed, I was mistreated, where OCD requires that ERP specialty treatment. And I was getting talk therapy instead. And talk therapy has actually been proven to make people with OCD worse. So it's getting a treatment from in-network providers, was getting worse, eventually hit rock bottom. I had to stop going to school. I stopped playing college football. I played at a very small school down in Texas, and then eventually became housebound. And so, out of desperation, one day at rock bottom, I was searching my symptoms online, and I saw that there are other people out there going through the same thing as me, and they defined what their experience as OCD. And so I was like, OCD, I thought that's just a personality quirk, right? Or an adjective used to describe somebody who's type A, right? You say like, oh, I'm so OCD about this, or my OCD made me, clean up my room. Like it just never really occurred to me that it was such a disabling condition. And I didn't realize it manifested in the way that it did. And so, for example, like you have these intrusive thoughts, images, and urges called obsessions. They could be violent, sexual, religious, relationship-based, existential, and they cause you to do these very specific actions called compulsions. And the compulsions are really the actions done by the person to make their obsessions go away, to try to make them stop, because the obsessions cause so much distress. So I had no idea about that. And so the next step was, well, where do I go get treatment? And started searching more. And there was one provider in my area. She was cash pay, completely out of network, and she charged about $350 per session. And she had a 7-month wait list. So only chance to get better was to wait in that wait list, was to see that provider. And fortunately, was able to jump through a couple hoops and was able to see the provider. She diagnosed me with OCD. She said, look, you have untreated OCD. That's why you're so severe right now. That's why you develop such bad depression. That's why your anxiety is through the roof, is because you just have this condition. And it's chronic. It affects 1 in 40 people, but it's also very manageable, right? So you're never going to cure it, but you can manage it to the point where you can live a healthy life. So she started me on the treatment. It was kind of a tough process because it's chronic. In between sessions, I was by myself, but nonetheless, got through the therapy, eventually regained my life. I went back to school. I went to Pomona College in Southern California and finished up my degree, finished up playing football, and was reflecting back thinking, 140 people suffer with this condition. It's extremely severe when untreated. It's ranked by the World Health Organization as a top 10 most disabling condition. It leads people to becoming 10 times more likely to die by suicide when untreated. But yet it's very manageable with ERP, right? So it's not a clinical issue, OCD. It's really an operational issue. We haven't done a good enough job raising awareness for what this condition is really like. People, recognize the term OCD as a personality quirk. Almost 100% of the US does, but yet very rarely do people know what it really means. At the same time, it's very difficult to access effective treatment. So you can't really get specialty ERP therapy in an easy way. And I realized that. I'm like, well, what if you changed it? What if you raised awareness for this condition? You help people understand OCD, and at the same time, you made it much easier for people to access ERP therapy, right? You could probably use technology to do that. And that's what we did at OCD. And so today we have a patient community of hundreds of thousands of people per month who engage with us either on our web content or inside of our platform. If they need therapy services, they can come in and they can access live face-to-face video sessions with a licensed therapist from our network that specializes in OCD and in ERP. And then between sessions, when that therapist isn't there, people can access always on support from different peer communities and self-help tools. And so we're growing exponentially, helping as many people as we can. And our team is the reason why. So really excited to be here, Solomon. You've talked to some of those folks today, but be happy to answer any questions that you have.
Well, why don't we start out with, it sounds like you had some pretty big news today. Tell our audience.
Sure. So we do have some big news. we've been able to work with a team of actuaries out in Santa Barbara called Santa Barbara Actuaries. They've been great partners of ours. And together, we've successfully quantified the cost of misdiagnosed and mistreated OCD. So it's the first time this has ever been done, given the fact that 96% of people with OCD do not surface in claims. They've been submarined in the data. And it's created an issue where the total cost of the population doesn't get shown to the healthcare system. So we've uncovered that cost, and we'd love to share what that cost really is. So in summary, if you have a million person population, we know the lifetime prevalence of OCD is 2.3%, and the 12-month prevalence is about 1.2%. And so if you look at that, right, today there's about $104 million worth of total cost generated by that population. 4 million of it is accounted for, about 100 million isn't. So we're essentially saying is we're paying for people with OCD to get access to clinically ineffective types of treatment that ultimately causes them to become higher utilizers of the system. So it really shows, it's like, look, if you simply were able to get people with OCD access to ERP at the right time, and you know, at the right setting, right, you can essentially curb costs by hundreds of millions of dollars per 1 million person population. So it's a huge savings opportunity nationally with payers today. And that's important because, to truly solve this problem, right, we're going to need everyone on board, right? We're going to need to make sure that there's complete alignment between providers, payers, patients, and even some life science firms too. And so it's a problem that is very large, and sadly it's affecting not only people but also their families. And so we can do something about it if we simply can come together and now start addressing this cost.
And why did you decide to commission this analysis?
Well, our team decided to commission this analysis because we work with many payers today, and we know together that most people with OCD do not service in claims, right? They get diagnosed as having anxiety, depression, symptoms of untreated OCD, and they oftentimes get coded then as having just anxiety and depression. Well, it's in fact correct to say they do have anxiety and depression, but the primary diagnosis, the reason why they're suffering, never really gets coded effectively. And so since we realized that issue with many of our payer partners today, we decided to take a step deeper and say, well, how can we really quantify the overall cost of OCD, knowing that if we can identify the cost and we can do something about it, not only is it a huge savings opportunity for patient or for payers, but most importantly, it's a major opportunity to save lives for patients, right? And then that's something that's central to our mission at NOCD. Our value is member first, right? We want to do everything that we can to help people with this condition. So that's why we commissioned this study is to help surface what's going on here with OCD. And now once we've surfaced it, we can actually do something about it.
I mean, this is totally groundbreaking. And I know the answer to this question, but I'll just ask you, how does this research support the mental health community, specifically the OCD community?
Sure. Well, and it's a great question, Salome. It's going to help the OCD community more easily access treatment long term. So once we understand the cost of OCD, what it allows us to then do is allows us to show, well, what happens if we didn't have this cost, right? And how do we actually do that? Well, we drive awareness. So all these people who are suffering today in silence will be able to learn that what they're going through may actually be OCD, or their loved ones will learn about that, and their family will, their friends will learn about it. So you have people who are close to them will also learn too. And so it's going to allow more people to access evidence-based ERP therapy before they develop comorbidities, before they get hospitalized, right? All these different issues that result because they're not getting the right care at the right place at the right time, we can mitigate those issues. And so I think when it comes to just the overall awareness, right, we have a chance to reduce the time it typically takes someone to get treatment from 14 to 17 years. That's the standard today, sadly, with OCD, down to maybe 14 to 17 hours. Just think about that, right? That's like, imagine being able to do that, or even come close to it. There's a huge opportunity, and it's a win-win all around for every stakeholder in the healthcare system.
I mean, that's totally shocking. What surprised you about the research?
What surprised me was the amount of costs dedicated to people who are bouncing from intensive outpatient to partial hospitalization to residential, back to IOP, back to PHP. I mean, the amount of the complexity in just the care pathway was what really surprised me. I mean, you hear about it anecdotally, right? I mean, we hear about it both as people who are big in the OCD community. Hey, look, someone has OCD. They finally got diagnosed, and then you ask them, well, what happened before? Well, I was at an IOP, I was at a PHP, I was misdiagnosed. I was put on an SSRI, I had 4 times too high of a prescription, right? And you hear about all the history, and you're like, oh, that's really challenging. And I guess what it showed me was that, anecdotal story is actually the norm. And it's a sad norm, right? But we can actually do something about it. It's just simply get access to this ERP therapy much sooner on in the journey, and identify people sooner on the journey. So we have an opportunity to identify and manage people much better here.
If you had to pick just one thing that you would want someone in the audience to walk away from this analysis, what would that be?
Well, OCD is not a joke, right? People oftentimes joke about it. I mean, we've been in conversations where someone will come into the conversation and say, like, I just tied my shoes extra tight today just to have this meeting. It's like, it's not a joke, right? This is a condition that is extremely severe. You wouldn't wish it on your worst enemy. I mean, I personally can tell you that there's nothing more crippling that I've ever gone through than this. And I'm not sure anyone else here in the audience who knows someone with OCD or has it personally I'm not sure if they could say the same thing. I'm sure many of them can. It's a very crippling condition, and it's also very manageable, right? So if you think about it, you think about SMIs, you have a lot of really severe people, and sometimes it's tough to get access to quality care, right? Because their treatments are effective, but they could be more effective, right? For OCD though, it's treated very effectively with ERP. So you have this very prevalent population that is severe when untreated, but because ERP is so effective, people can get to a subclinical level. And why that's that important is because you can make a very quick impact just by focusing on OCD. And that's something that everyone should take away. It's like, if you simply just focus on this population, there's a massive opportunity that's low hanging, and you can capitalize on it. And the best part about it is you're going to help millions of people by doing it.
It's amazing. This stuff does work. We just have to get the right treatment to the right place, as you said.
Yeah.
As you know, this is something I've also struggled with since I've been an adolescent. And this is just such meaningful work that you're doing to help so many people.
So Soulmate, a quick question here too. Like, if based on your personal experience, if you had to pick one thing the audience could walk away with from just learning about OCD, what would it be?
For me, it took, as you alluded to, years to figure out what it was that I was actually dealing with. No one in my family even had a vocabulary for OCD. So we still have a long way to go in terms of education around what this condition is, because it's not just about what we're seeing in the media, which, as you know, is a total misconception, but people are struggling and don't even know what it is they're dealing with.
Mm-hmm. Yeah, totally.
Truly, thank you, Stephen.
Yeah.
I'm going to turn it over to Dr. Feusner now for a few more questions.
Hi, I'm Dr. Jaime Feusner, and I'm the Chief Medical Officer at NOCD. I'm also a professor of psychiatry at UCLA, and I'm the director of our UCLA OCD Intensive Treatment Program.
Dr. Feizner, you've published and led a lot of clinical research. From a clinical perspective, what makes this analysis different?
So a lot of clinical research in OCD or other psychiatric disorders, it kind of starts with people who who have OCD. So these are people that are either representing in a clinic, or they're being recruited for a study and then they're diagnosed with OCD. So in essence, a lot of clinical research is about people whom we know have OCD. This research is more about who may have OCD who is not surfacing. In other words, how many people in a healthcare system might have OCD but have not been diagnosed correctly?
So from your perspective, what does this say about the current state of OCD care in the United States healthcare system?
So the research that we did, so this is a study that we commissioned on 1 million people in a healthcare system over 12 consecutive months. And the purpose of the research was to understand how many of these people in this healthcare system were being diagnosed with OCD, and what proportion of the people in the system, if they weren't being diagnosed with OCD, have a probable OCD diagnosis. So in other words, they may be seeking mental health care for another problem. It could be what we consider a comorbid problem, so a problem that exists in addition to OCD, like depression, an anxiety disorder problem, a substance use problem. And they may be presenting care for that, but the core problem they experience is actually OCD. So we wanted to try to understand what proportion of the healthcare system was being properly diagnosed compared to what we would expect to see in this population based on the prevalence of OCD in the general population. And then secondly, we wanted to understand what are the costs that are incurred by people in the healthcare system who have been diagnosed with OCD, and what are the costs of the people who have a probable OCD diagnosis, but either didn't receive any diagnosis at all, or they were misdiagnosed essentially. So the results that were really critical that we found, this was surprising to me because the numbers are so large, so that means that the healthcare system is really failing in a major way. Failing in the sense that about 90% of people with OCD are either being misdiagnosed or they're not being diagnosed at all. So this failure of the healthcare system for OCD, I think, is surprising on the one hand. On the other hand, it's also somewhat understandable, or at least kind of explainable by the nature of OCD itself. On the one hand, because OCD is sometimes hard to diagnose, and particularly if somebody has a type of symptom that's not a classic textbook symptom of washing their hands excessively, or checking things over and over again, or maybe needing to have things lined up or ordered in a certain way, but are a different type of OCD symptom that we sometimes call harm OCD or intrusive negative thoughts. So these are people with OCD who have thoughts that are very disturbing to them, that they don't like, thoughts that might have to do with some kind of theme of harm, or something that really kind of goes against their character, that feels very disturbing to them, and they can't get the thoughts out of their mind. And that type of OCD symptom is not as commonly recognized as OCD, and it might be misdiagnosed as, say, generalized anxiety, or completely missed it all, or some other anxiety problem, or the person might experience depression, is misdiagnosed as depression, or the person might end up developing a substance use problem, and then that is what kind of brings the person to attention. So it's understandable why that OCD diagnosis might be missed, and people with OCD themselves may not understand that that type of OCD is OCD. Then another part of the problem, I think, in the healthcare system, or more of kind of the explanation about why so many may be missed, is that unfortunately not a lot of healthcare providers are adequately trained to identify and diagnose OCD. And that's part of I think a systematic problem that happens in training in many schools. So when psychotherapists are being trained in different disciplines, and psychiatrists, I think they just don't receive quite enough training and education about OCD, and especially these kind of non-classic subtypes of OCD. So another issue about the non-classic subtypes of OCD is that they actually are most likely more common than the checking and the contamination fears and washing symptoms. So we're looking at the most common type of OCD is actually the type that's missed most often. So our healthcare system has a lot of work to do, I think, in both recognizing OCD, and then also the second part of it is then treating them appropriately.
Wow, majorly underdiagnosed. What else did this research answer for you in terms of what you might not have known before the research was completed?
Yeah, so also the research then looked at the costs associated with healthcare for people with OCD. And the costs can vary quite a bit. So, the range can be anywhere up to $125,000 per year per person to on the lower end of about $2,600 per year, for people who are actually getting treatment for OCD. So there's a very wide range. And what we did in our research is we looked at the different pathways that people with OCD might traverse as they go through the healthcare system. So a pathway could be something like perhaps somebody is diagnosed with OCD by a psychotherapist or by a psychiatrist to start with, or could be a primary care doctor. And then let's say that person is referred to outpatient psychotherapy for treatment. Then that person might be in that kind of outpatient track. Basically, they might be seeing a therapist, say, once a week. Maybe they're also referred to a psychiatrist whom they see once every few months or so. So that might represent kind of on the low end of acuity. But when people are not receiving care that is effective enough for them, so if the person isn't getting better with OCD, then they might be referred to a higher level of care. And the different types of higher level of care for OCD could include an intensive outpatient program. So that's where they're doing therapy more than once a week, usually 2, 3, or up to 5 times a week, or a partial hospitalization program where they're essentially going for about a half or even a full day of treatment, but they don't stay overnight. Or it could be a residential treatment where they are essentially living in a place where they're receiving treatment, or it could be an inpatient hospital. So that's kind of the highest level of care. And so these different pathways that people might traverse is, let's say that they don't do well enough in the first level outpatient care, then they might be referred to an intensive outpatient program. And if they do well there and they're getting treatment, they're getting better, then they might move back down to an outpatient treatment once a week. If they're not getting better from that, they might move up to, say, a partial hospitalization program or a residential program or an inpatient psychiatric hospital if they're really not doing very well at all. And then after that, they might be transitioned down to like a slightly lower of care. And let's say within a year, maybe they go back down to outpatient, but then they relapse, or the symptoms maybe were never really treated sufficiently. Then they might go back up to a higher level of care. So you can imagine there's a lot of different combinations of pathways that people could take, and each pathway essentially has a different cost associated with it. So our research, we're able to identify in actual members to see what their pathways were, and then we could see the costs of all these different pathways. And that way we can get a sense of, okay, if somebody with OCD is being treated properly, so if they're receiving an effective type of treatment, and the two gold standard effective treatments for OCD are a type of therapy that's called exposure and response prevention therapy, which is a subtype of cognitive behavioral therapy, and it's particularly effective for OCD. And also medication. So serotonin reuptake inhibitors are considered first-line treatment for OCD. So if they, let's say, are not receiving an effective care at that first level, they may end up having to transition up to higher care. But if they are receiving effective care, a large proportion of those people wouldn't need to transition to the different levels. And that represents potentially a very large health savings. Because if somebody can be on the low end of, on average, about $2,600 a year, compared to on the higher end of like dozens or even $100,000 a year for treatment, because they were identified correctly in the beginning, they were diagnosed appropriately, and they received the effective type of treatment for OCD in the beginning, then that can save quite a bit of money. And unfortunately, the state of affairs in the healthcare system in the United States mostly is that, unfortunately, a lot of people with OCD don't get that appropriate care, either because it's not available, there aren't enough therapists who have that training, or they're referred to the wrong treatment that's not like a first-line treatment. So this research really helped us identify what are potential cost savings that could happen when people with OCD receive effective evidence-based treatment, as opposed to ones that either are treating a different problem, like a secondary depression or a secondary substance problem, rather than the core OCD problem. And the research really suggests that there's potentially a very large healthcare savings associated with effective evidence-based treatment that's applied hopefully early on when the person gets diagnosed.
Wow, this is breakthrough, really huge for the field of OCD and for all of the individuals who are struggling. I'm really excited about this news. Well, thank you so much for this incredible work that you've done. As I said earlier, this is so meaningful, and not only from a cost perspective, but as I've talked about before, this is something I've struggled with personally, and just the impact that it has on individuals and families is so significant. So really excited about this news. Thank you so much, Stephen and Dr. Feizner, for your time and expertise here. I'm excited for the audience to go read the study, and everyone, please take some time to check out their booth and learn more.